to welcome all the speakers for our conference, and I have to thank Dr. Muhammad for his great effort. And I think our first speaker, I think Professor Nihal Shakankiri, she's a professor of pediatric University of Mayan University in Alexandria. And I think her talk, it will be in traumatic, they remove the screen, in traumatic cataract with anterior and posterior capsule defect. Please, Dr. Nihal, the floor is for you. Can you hear me, Dr. Nihal?
Yes.
Yeah, you can share your screen.
I'm going to speak about traumatic cataract with defects in the anterior and posterior capsule. Not always the traumatic cataract is like that, straightforward, where you can have a transparent anterior capsule where you perform a straightforward anterior capsulorhexis, and you have a beautiful posterior capsule where you go for a hooking, tenting, and tearing into a triangular tear and injection of viscoelastic inside the burger space, and then performing the straightforward posterior capsulorhexis we all know, simple because of transparent posterior capsule, 4 millimeters anterior vitrectomy, and then inject the IOL inside the capsular bag between the two rhexes. Sometimes we face defects in the anterior capsule with different sizes and different shapes, or defects in the posterior capsule that may be small or large, central or eccentric. And sometimes we are faced with the combined defects of the anterior and posterior capsule. Sometimes we have more difficult cases, not only tears in the anterior and posterior capsule, but sometimes we have dialysis combined with the dialysis, or iridodialysis, or synechia or fibrosis of both the anterior and posterior capsule. To start with, anterior capsular defects or tears. How to deal in these cases? The defects may be central or may be peripheral. In cases of small peripheral tears in the anterior capsule, we perform the anterior capsulorhexis in the conventional way, like that, until we meet an area of fibrosis, and we cut with micro scissors, and then we continue to perform the anterior rhexis 5 millimeters. Here, after irrigation aspiration, you see this is the anterior rhexis, and this is a defect. We have to leave a hinge or a fibrous band. We don't make them continuous with each other. And then we continue posterior rhexis. Here with magnification, you see this bridge, fibrous bridge between the anterior rhexis and the defect. Why? In order to inject the intraocular lens inside the capsular bag, you see here that the IOL beautifully placed, and you have partial fibrosis of the posterior capsule. And this is the bridge between the anterior rhexis and anterior capsular defect. Sometimes the peripheral defect like this, you can see the edge, the whole edge of the defect. It's a sort of a paracentral defect in the anterior capsule. How to deal? We first inject viscoelastic inside the capsular bag in order to facilitate aspiration of the remnants of the cortex. And we have here the defect with a fibrotic edge. How to deal? With the side port, we enter with a micro scissors 23 gauge. We cut the fibrotic edge, and then we go through the side port with a rhexis 25 gauge, and we make the anterior capsulorhexis until we reach the fibrotic part, this fibrotic part. We enter again with the side port and we cut this fibrotic edge. So we're going to be left with a beautiful curvy linear anterior capsulorhexis. Here with magnification, partially in a transparent capsule and partially fibrotic, but it is continuous. And we can continue capsulorhexis, anterior vitrectomy, and then injection of the intraocular lens beautifully inside the capsular bag between the two rhexis. But sometimes we have the peripheral defect in the anterior capsule. We cannot see the peripheral edge of the defect. In these cases, we make half anterior rhexis. We cut the edge of the anterior capsule, and then with the rhexis forceps, we make half anterior rexes. And here, after irrigation aspiration, we continue in the conventional way, and we can even implant the IOL inside the capsular bag. So whenever we have a defect in the anterior capsule, we try to preserve any remnants of the anterior capsule. Even if it extends both sides like this, we can perform the posterior rexes and implant the IOL inside the bag despite having tears from both sides like that. Concerning posterior capsular defect is so variable. It may be central, it may be peripheral, it may be small, or maybe large. The large posterior capsular defect may have fibrotic edges or may have here extending to the periphery and extremely irregular. How to deal with these defects? In cases with a peripheral posterior capsular defect, we perform the posterior rexes in the conventional way, anterior vitrectomy, and inject the IOL inside the capsular bag, but care should be taken that the axis of the IOL should be parallel to the defect. Here, there's another case of small defect, but it is paracentral, and the child gave a history of intravitreal injection of Lucentis because he was a premature baby. Here you can see the defect before surgery. After irrigation aspiration, this is a paracentral defect associated with fibrosis of the posterior capsule. How to deal? We make posterior capsular rexes, and since it is paracentral, we include the defect in the posterior rexes, and still we can implant the IOL inside the bag between the anterior and posterior rexes. But in cases of a large defect, as in this case, it is diagnosed by a UBM, how to deal in large defects? The key of success in these cases is the anterior capsular rexes, which should be exactly 5 millimeter, and it should be exactly central. After irrigation aspiration, first, before deciding what to do, we have to go for vitrectomy to clear the edge of the tear from vitreous. And then we decide. You can see here the edge is sharp and it goes beyond the edge of the anterior capsular rexes. So in these cases, we remove totally the posterior capsule, implant the IOL in sulcus, and then we can safely perform optic capture technique in the anterior rexes. And this is a case of optic capture technique. It is beautiful, as if implanting inside the capsular bag. In some cases, with a large defect, after vitrectomy and aspiration, we are left with a large defect, but look here, it is a fibrotic and curved, the upper part and the lower part of the defect. In these cases, we can even polish the anterior capsule, and then we can inject the IOL inside the capsular bag between rexes, anterior rexes, and this a huge defect because we have a round edge of the defect that cannot extend. But in cases with a large defect that is totally irregular and you cannot see its edge, there is no way. You have to remove the posterior capsule, implant in sulcus, and perform optic capture technique. The last thing is combined anterior and posterior capsular defect. Look here, there is a defect in the anterior capsule, and here with magnification. During irrigation aspiration, there is another defect in the posterior capsule. In these cases, care should be taken. We should go with the cutter, but take care not to damage the remnants of the anterior and posterior capsule. So you go for vitrectomy combined with aspiration until you finish irrigation aspiration. Look here, this is a longitudinal huge defect in the anterior capsule and another vertical defect in the posterior capsule. How to proceed? We go with a side port and with vinyl scissors, with a micro scissors, and then we cut the edge of the anterior capsular flap, and we make it somewhat semicircular. And then from the other side port, we cut in the posterior capsular flap, make it circular. We perform anterior vitrectomy, and then we are left with a beautiful support, partly by the anterior capsule and partly by the posterior capsule, where we can inject a multi-piece intraocular lens in sulcus supported by this capsule. Sometimes it is more and more difficult cases. We have zonular dehiscence and fibrosis. how to deal. We make the anterior capsular axis, and then we make the posterior capsular axis, and we inject the IOL in bag away and parallel to the pathology in the temporal part. Here, 1 year after surgery. This is before, few weeks after surgery, few months after surgery, the child here with the clear visual axis and the refraction.
Professor, can you conclude, please?
Yes, this is before and after surgery. Finally, to conclude, traumatic cataract in children can yield good postoperative results, even with tears in the anterior capsule or tears in the posterior capsule. This is optic capture technique, but you should go for an excellent primary rupture globe. If it is good, you can have good visual results after anterior and posterior capsular defect. And thank you very much for your kind attention.
Thank you, Prof. Thank you. Dr. Hayat, please, Professor Ken, he has to leave after 20 minutes. So if we can bring, please, my professor, and he, yeah.
So we can take Dr. Ken Nischal first. I would like to introduce Dr. Ken Nischal, need no introduction. He is the Chief of Pediatric Division at Pittsburgh, and he'll take the stage. And we are just would like to take him first. Thank you very much.
Thank you. I appreciate that very much. Thank you so much for inviting me. Magdi, it is so nice to see you after all these years. Magdi and I worked together at Al-Qasimi Hospital in the early 2000s, so it's very nice to see you again. Thank you very much for asking me to speak. And I'm talking about management of unusual cataract presentations. These are my disclosures. None of them are relevant to today's talk. So I'm going to talk about two unusual cases. Both utilize what I would consider to be an intracapsular aspiration technique, and both are cases that you can apply in other circumstances. So the first case is a 5-year-old male. He had bilateral Peters anomaly. I did bilateral penetrating keratoplasty at the age of 4 months. These are the original grafts. He now has a significant cataract in the left eye, and you can see the right eye has a good red reflex. The left eye reflex is dull, but the cornea is pretty clear, and you can see on the OCT the cataract. So endothelial cell loss after PKP, there are very few reports describing this in children. There is one report showing 59% loss at 49 months, but we know that when infants undergo PKP, especially for Peters anomaly, the probability of a clear graft survival is low, right? 35% at 10 years. We also know that you get endothelial cell loss after cataract surgery. In fact, Choi et al. Reported about 20% loss at 10 years, which is a yearly rate of about 2%. That's much higher than the physiological aging process, which is 0.6% per year. And we know that there's an accelerated loss if you are operating for lensectomy and lens aspiration for congenital cataract. So here we have a child who's had a PKP, so he has endothelial cell loss already, is going to have a cataract operation. How do we reduce the endothelial cell loss? So the proposed technique is an intracapsular lensectomy. I'm going to show you that, and the sandwich viscoelastic technique. So here is a schematic. I use dispersive viscoat to coat the endothelium, and then I use cohesive viscoelastic, Helon GV, to between the iris and the layer of viscoat, and this is what I call the sandwich technique. So the first thing is I'm going paralimbal, and in this case, I have some peripheral iridectomies, which is part of my PKP technique to prevent secondary glaucoma, and I am inside the bag, okay? That's the important thing. And I've made my second stab, and now I put my irrigation aspiration into the bag. My height of my irrigation bottle must be low, because you don't want to expand the capsule and the openings that you've made be ripped open. So I'm going into the lens, and I am underneath the anterior capsule, underneath the anterior capsule. This is really important because the endothelial cell loss occurs because of the turbulence of the irrigation fluid up against the endothelium. If you're underneath the anterior capsule, you don't get that. You reduce that loss by operating in the bag. And you'll see here that I use my irrigating cannula every so often to rub the port of my aspirating cannula so that I don't run into problems of not being able to aspirate. You can already see a good red reflex. And now what I'm doing is I'm sort of polishing and cleaning at the equator and as much as I can. And here's a really nice real-time video. Look, the anterior capsule, as seen here, I hope you can see my my arrow, is intact. I'm operating in the bag, and this is a useful technique to protect the endothelium. So, what I want to show you is, this is just the real-time video. I'm not going to show you that. I want to show you at the end, this is what it looks like. But here's the important thing. I fill the bag with, at the bottom here, on the bottom right, with Helon GV, and I do my posterior capsulectomy relatively dry, and then I introduce my infusion to do my anterior vitrectomy. Then I can do my anterior capsulectomy, and all the time I've got minimal turbulence. So this is really important. So that's my first example. This is another example. And many of you know that I like to think about congenital corneal opacities as primary corneal disease and secondary corneal disease. In this classification, I have one classification that says mechanical, for example, due to PHPV. I want to show you a case that was referred to me as Peter's anomaly. But when I looked at this case, there was something striking. And what was striking was that the anterior chamber was very shallow, very shallow. In fact, when I did the anterior segment OCT, look, you can see here, I'm just going to put my laser pointer on so you can see it clearly. This is the iris pushed up against the cornea, and here is the lens. Now, this lens is not embryologically attached to the cornea. If that happens, you get disruption of the endothelial decimase. This is a lens that is being pushed forward. So I want to now introduce you to this paper that I wrote, Cataract Surgery in Children with Congenital Keratolenticule Adhesion. You don't always have to do a corneal transplant if you have a Peters anomaly type 2. Now, this particular case is not a Peters anomaly type 2. It is a mechanical touch of the lens. So what I do, again, I go in at the limbus and I enter the bag. I do irrigation aspiration, I decompress the lens, and then I can do my capsulectomy, both anterior and posterior, and my vitrectomy. So if you look here, after I've done that in this case, you can see that the capsule is hanging down because I have decompressed the lens, and the iris I've pushed back with viscoelastic. Now, when I continue to do my capsulectomy, look what I find. I've taken my anterior capsulectomy away. I'm using a endoilluminator. This is a plaque on the posterior capsule. These are the ciliary processes being dragged in. This is a case of PHPV. A case of PHPV. Very carefully, I take away the plaque, I release the tension on the ciliary processes, and after 6 months, the child looks like this. I cannot take away the opacity, but the child has a clear window, and with an aphakic contact lens, we get the vision up to 21-25. So without doing a corneal transplant, and by recognizing what the problem was, you're able, through the intracapsular aspiration, to get a very good result in what is a difficult case. So here's my take-home message. My take-home message is intracapsular cataract aspiration is a useful technique to have up your sleeve, and it can be applicable in various unusual pediatric cataracts. And I hope I've gained some time for you guys by giving my talk. Thank you so much for inviting me. It's been a real pleasure.
Thank you, Ken. Ken, I have a quick question here. It's amazing. Both the videos, amazing work, absolutely cutting edge. And my question here is that, which is the instrument you use to do the capsulotomy? Is it the cutter or is it, which one do you follow?
So in the first case, I did the anterior capsular opening with an microforceps, like the one that the previous Dr. Hilary was showing us, Dr. Nihal was showing us, sorry. But the posterior capsule I did with the vitrector because I was going to do the vitrectomy anyway. And I wasn't going to put a lens in the eye, obviously.
Fair enough. Any other panelists have any questions? Dr. Nihal, would you like to add? Okay. If so is the case, then we can go now to Dr. Mustafa, who's there from Jordan. He's going to take the next interesting talk on Yamani IOL fixation. Please, all yours.
So, Assalamu alaikum. Good evening to everyone. Thank you for the organizing committee for allowing me to share with you this talk. I'm presenting a video presentation on traumatic cataract management, highlighting two aspects: the IOL fixation in absence of complete absence, let me say, after Dr. Nihal's talk, of capsular support, and the management of iris defects. So to start, before the start of the operation, we have to do markings for the Yamani technique. It's very important to put marks 180 degrees apart at 0 and 100, and then go out 2 millimeters from the imbus, and on the right side go up 2 millimeters, and on the other side 2 millimeters out and down 2 millimeters, and then start the vitrectomy, taking out all the soft lens matter, any adhesions and remnants of the capsule. In this case, the initial injury was repaired a week before at primary repair, as you can see. For the Yamani technique, it's important to do a good vitrectomy so as to avoid the entrapment of the vitreous into the lens. Next step in this case was doing the pupilloplasty using the Capsular sliding knot technique. Helium injected into the eye, and then paracentesis was made at the appropriate position to allow for good capture of the iris. I used a 10-0 Prolene needle, Prolene suture on a long straight needle. The needle is passed through the first edge of the iris and then through the second lip of the iris defect. Forceps can be used to help support the tissues, and then the needle is passed through the cornea all the way out. At this point, we have the straight thread of the suture going through the paracentesis, the two edges or the two lips of the iris, and then through the cornea to the other side. Push-pull instrument is then used to pull a loop from the suture just between the second lip of the iris wound edge, and it's pulled out. Now we have two sides of the suture on the same side coming through the paracentesis. If you hold the part of the loop that goes all the way through the cornea to the other side and avoid the one that goes to the iris, you can use that edge to make a 4-throw knot, and this knot is then gently slid into the eye through the paracentesis by pulling the two edges of the suture, the 10-0 Prolene suture. And as you can see, the edges of the iris are approximated to make the pupil roundish again. Usually this is sufficient, but sometimes you may want to put a locking bite, and the same maneuver is done. A loop is made, hold the part of the loop that goes all the way through the cornea and make one throw to do your locking bite, and again gently the sutures are pulled apart to slide the knot back into place. The edges of the suture or the knot can be cut either by a microcapsular micro scissors, or if a main incision to put the IOL is made, you can then use the regular micro scissors. Next step would be to insert the IOL through the main wound, and we use a 3-piece foldable IOL, either a thickness lens or an Alcon lens. This is an Alcon MA60 3-piece lens. As you can see, the lens is gently inserted into the anterior chamber and allowed to rest on the surface of the iris. The trailing haptic is left outside the eye, and this is the appearance as you can see at the end of the insertion. Now we start with the fixation of the lens. 30 gauge ultra-thin wall needle is used to allow for a large lumen to allow for the threading of the haptics. It's marked at 2 millimeters to start the tunnel that goes through the conjunctiva and into the sclera. Make sure to hold the eye tight with the forceps. When you reach the 2 millimeter point, rotate the lens, the needle towards the center of the cornea, to the center of the eye, and you can see the edge of the needle coming behind the iris. Then with a straight micro forceps, the haptic is held and then threaded through or laced into the opening of the needle. Once this is done sufficiently, maybe 1 or 2 millimeters of the haptic is pushed into the opening of the lens, the needle is gently rotated and pulled out of the eye, making sure to hold tying forceps in the other hand to grab the haptic as soon as it comes out, so as not to allow it to slid or slip immediately back into the eye, and this can happen if it's not caught immediately. With a low temperature cautery, a small bulb or flange is made at the edge of the haptic. This will prevent the haptic from going back through the scleral tunnel. The trailing haptic is then gently put into the anterior chamber, making sure not to cause a lot of tension on the optic haptic junctions. Then on the other side, the same is done. Make sure it's 2 millimeters. In this case, it was more, so again, a 2 millimeter mark is put on the needle. To be able to do a good or construct a good tunnel, the pressure in the eye needs to be hard. This eye was softish, so extra amounts of healing were injected into the eye to make sure that the pressure in the eye is high enough to allow for a good tunnel construction. AC maintainer is another option in these cases. So again, scleral tunnel, 2 millimeters in the direction, and then once this is reached, the needle is rotated towards the center of the eye, and you can see the needle tip again behind the iris. Using the same micro forceps, the trailing haptic is held. Sometimes this is a little bit difficult because it's pushed towards the angle.
Can we conclude?
I'm about to finish. And then the same is done. The haptic is fed through the needle and it's pulled out, and again we do the same. So in conclusion, this is the appearance of the eye 1 week after the operation, quiet eye, and you can see in the photo at the edge the tip of the haptic. Just quick tips: use large lumen 30 gauge needle, keep the eye firm using AC maintainer or Helon. Make sure that the entry points are 180 degrees apart. You can use any type of lens, 3-piece foldable lens, the thickness of the Alcon lenses. And thank you very much. I still have 20 seconds.
Yeah, no. The thing is, I just want to convey that we have 10 minutes break after this. So, Dr. Mustafa, please, if you have, please go ahead.
It's okay. It's okay. It's okay.
Yeah. Yes. So, thank you so much, Dr. Mustafa. And now the stage is for Professor S.K. Coker from All India Institute of Medical Sciences in India, and he'll take the stage to discuss an interesting pediatric of cataract cases. Thank you, please.
Thank you, Dr. Hayat. Just tell me whenever you can see my slides, then I can get going. So you
just
promised
a small
me
announcement that announcement that we have more time. Dr. Majdi just got a message that we have 10 minutes break. So please take your time so that we can enjoy these sessions.
Perfect. So that's good. Can you see my slides now?
Yes.
And if the first video doesn't run, that means it's not going to run. So I'll go first up, run my videos, and come back to you again, right? I think that'll be better.
Go ahead. Go ahead.
There we go. So I'll just go there, and yeah, it works. So okay, we can go back now. Perfect now. So we have just seen beautiful surgeries done by Nihal, Professor Nihal. I mean, wonderful concepts from Ken Nischel. So let's see what happens when the eye is not the size which you expect. You expect a good size of the eye. If you have a patient of a rubella, you might have a smaller eyes with the partially absorbed cataract. Of course, you're putting lenses in those ones. So how do you plan these smaller eyes or the bigger eyes? With my colleagues from the glaucoma section, they do the ophthalmic surgeries for the glaucoma and they send back to us. So if they have a cataract, is it the routine cataract we're doing or there's something else? So let's see how we go about this. And that's we've been doing for last around 15 to 20 years. I just picked up a few videos so I can finish in my 10 to 11 minutes time. The surgeries in large eyes, basically two categories. One is a ophthalmos, and that's the one which I like to highlight because that's the one which is with the increased IOP. So what happens because of that, the size of the cornea is big. So any cornea which is more than 12 millimeters after 1 year of age of the child is abnormal. That's what is the American Academy concept. And anything which is greater than 13 millimeter of mm at any age is a highly glaucoma suspect. And if you have high pressure, along with that, if you have those obstructs and all that, you have proven case of a ophthalmos. Okay, so the cornea after 3 years stopped growing, so the cornea diameters might not change. So the ophthalmos might stay stable after the age of 3 years, but the sclera keeps stretching at the back. So the eyes are going bigger and bigger and bigger. Okay, so see, this patient is about a 16 millimeter across. There's a cataract there. TRAB has been done when the child was, I think, 2 months of age. Professor Ramanjit, one of the best surgeons at a place, has done the trabectomy, and the patient has been sent to me for the cataract. Now you see the rexus of mine anterior looks small, but that's it's an optical illusion because this rexus is 5 millimeter of size, but the eye is big. See, it's a huge eye. And I make a small nick at the posterior capsule and I hold it. And you see how easily it's running because there's no firm vitreous which is holding it back. So since the expansion of the globe, the vitreous starts falling apart from all the sides. And that's 2 round rexes, almost 5 millimeter. Hardly any vitrectomy to be done, but let's just go and finish up few lamellas. Now, if I put a single piece lens, which is 12.5 millimeter across, it'll be moving inside the bag. It'll be juggling all around. I don't want that. So the answer is you put a 3-piece lens in the sulcus and capture the optic with anterior posterior both. So you make the lens an integral part of the bag. So that's how you should do it. And that's how this surgery was done. Okay, now case number 2 is a megalocornea. And in this, there's a fibrosis anterior capsule. The exit length is 25 millimeter each. And wide to wide, the corneal diameter is 12.6. So this is what it looks like now. So when we saw this patient on a UBM, we do UBM for all the patient, you can see there's an anterior plaque. So I can't do a nick and do a rexus in this patient. However good I am, I'm not a Superman. So what you need to do is you need to give a nick onto the fibrotic capsule, and see that ring in the center is 5 millimeter. If you can notice, this ring is 5 millimeter. So if I go around it, my rexus will become too big. So I'm going inside and cutting with my scissors. So that's the other technique we use, especially for the anterior plaque and the bigger eyes. Once you've done it from one side, you reach the limit, you can come out from the other side and start doing that. And I've got 6 minutes left. I'm looking at the clock also. So once you come from the other side, you can nick it a little more. Okay, but since you're cutting with a longer forceps, it cannot be symmetrical cut all around. What I'm trying to tell you is that there might be little bigger tags left somewhere, which we can handle after putting in the implant in these patients. So now I aspirated this one. The cortical aspiration is the easiest bit in this entire gamut of the surgery, because the anterior axis is a little problem because of the fibrosis, and posterior axis, again, because it's of the elastic nature of the capsule. So you see the anterior capsule is not cut completely. So but there's nothing to worry, because we got things open at the back and we can always come back to this. And this was not a traumatic cataract. So this kid was born with this, and there's a plaque there, and the eye size was big. And since the cornea is clear, no scar, no hub strias, so this was a case of a megalocornea rather than a ophthalmus. So I'll just go up a little bit, and then we go and do the posterior axis in this one. Posterior axis as such is not very difficult in this patient. So once the posterior axis is achieved, I'm trying to aspirate all cortex before I actually touch the posterior capsule. And there it goes. I thought I'll divide 5 minutes each for both the talks, but I think it's already going 6. So I'll just rush it down a bit. Okay. All right. So I'm doing a posterior axis again, because it's a bigger eyeball. It's very easy to operate. Is it? Because the smaller eye is a problem. Even the bigger eyes can have its own issues when you're handling rexus in these patients. So basically now the posterior axis is done and the implant goes in. And on the UBM we measured, and this eye again, I'm putting a 3-piece implant. Whenever I find my white to white diameter is more than 13 millimeter, and my bag diameter inside is also about 11 to 12, I'm putting 3-piece lenses as a capture. It works wonderfully well. And see, there's a little fibrotic scar in the front. In fact, that is going to help me to keep the lens in place, and that's how beautifully it looks like. Okay, so this is another patient which 5 years old with a subluxated lens, and you see on the UBM the lens is coming anterior, and the globe is big. The globe is about 14 millimeter both eyes. So this surgery has already been completed, interlenticular aspiration, which we have already published our own technique, which we use a cutter rather than a bimanual aspiration, which Ken has shown you. So see, I'm making a 5.2 entry. I'm going to put an iris claw lens. So either you put a 3-piece lens if you have a support. If you don't have a support, I think iris claw is better in these ones. There's no point in putting fixated lenses in the globes, which are already stretching and becoming pinned out in the periphery, because it won't sustain well. You see how well you can see the impression of the claw through the iris, and you're able to put it and just tuck it, and that's about it. And put a suture. Make sure you put 2 sutures because it's a 5.2 incision. Okay. So surgical difficulties you see here are deep chamber. So difficult instrumentation. There could be donuses. There could be zonular donuses. Could be phacodonuses, liquidated vitreous. All these things can add on to your miseries. So let's go. So there's another paper which is by Vinisa and all, in which they put an AC lens in these patients, and they've got good results. So coming to the smaller eyes, any eye which is less than 2 standard deviations smaller for the age is a microphthalmus. Normally less than 20 they say small, but what we say is get us 10 to 15 millimeter pupil, both eyes white to white. So what do you do in these patients? What you need to do is that you got to be careful, because these eyes will have other systemic eye problems also, like they can have ectopia lentis, they can have retinal detachments, they can have persistent fetal vasculature and coloboma. So not only the surgery, you have to make sure that the first time the kids are coming to you, they're 1 month or 2 months old, you have to take the pictures of the fundus also. And there's a technique which we started using at the center. I'm going to show you about that also. So since the IOL is not going to be put, we can do both the eyes simultaneously. So when I say simultaneously, it means the doctor has to get up and scrub again and come back. Or there are 2 sets of surgeons. One gets up, the entire team goes out, the entire team comes in with a new machine. And that's what you can do. And we only use cutters in these, not use bimanuals. And we can use IA cut or cut IA. I'll show you in the video how we do that. These are quicker surgeries because both eyes can be done quickly. We are not going to show us to the rexus and waste time there, because these eyes may not be getting lenses at all in their entire life. Or if they grow up, they might get a 3-piece lens in the sulcus later on. Retinal evaluation is a must in these patients. And that's what we're going to show you here. And UBM in the master lesion patient. So this is what it looks like. A smaller eye, you can use a caliper to measure it. And a UBM, I think, is a gold standard to measure it. So if see on this patient in this UBM, my bag is about a 5.9. If I stretch it a little more, it might become 6, and that's about it. So how can a 12.5 lens go inside? So this is a big no for these ones. So this is one of the surgeries. Now see, it's a small eye. You see the atrophic iris pattern there, and this is the maximum dilatation. And this dilatation is not even 4.5. So what I'm trying to do is, just for my residents, we can do a rexis on the anterior, and then I do with a cut, go with a cutter, do in the IA cut mode, aspirate the cortex, and then I open the posterior capsule with that. And at the end, I always do a PI because these are the crowded eyes and is the crowding in the periphery. So that's how the surgery finishes off. So this is a second patient in which the axilla is 16 millimeters, a smaller eye, and the white to white is 8 millimeters. Of course, there is no implant planned in this one. So this is a UBM we do. Now see the eye, we make side ports, and that's good enough. And these two side ports are MVR, which is 1 millimeter, so you don't have to suture them at all. So I do a cut IA, I open the anterior capsule, then I switch over to IA cut, aspiration and cut. And then once I finish that, again, I go to the cut IA mode of the vitrectomy probe. With the same probe in the eye, I just flip my foot pedal to switch over my modes, and I can finish up the entire surgery in maybe less than 2 minutes in each eye. So this patient, both eyes were done. So this is, in fact, you can use biomanual to take the cortex, but if you notice my left hand, I bring under the cortex and peel it off. So it's pulling it off. And see that 5 millimeter ring is almost touching the pupil. It's just, so the entire eye is about 8 millimeters, and this entire pupil right now is less than 5 millimeters, at 4.5. And that's the end. But before the end, we put in a illuminator inside the eye and try to see the retina. And this is the first time anybody is looking into the back, into the front. The kid comes to an age of 1 year, 2 years, maybe a few months, in fact. And so you take a picture on a by putting the lens on the top and stay the document, and you see the follow-up with this patient and tell the parents the prognosis. So that definition, I always do a PI in these smaller eyes. So that's how one has done. So this is what I was talking about, the wide angle. So we published this work in BMJ about a year back. So see one picture on the right here, it's got a detachment at the back, which is quite commonly associated with the smaller eye. The second picture has got a PFB, persistent fetal vasculature. Now this patient didn't have a phobia at all. And this was, I think, 30 months old kid. And this last month had a scar. So we could document it on the table. And whenever the patient comes to us, we have the records with us. And we give a copy to the patient also. This is a very small technique. Since you're already doing vitrectomy, you don't have to go with the light probe all the way. From the limbus, you can go stay in the pupillary plane. That light is good enough to pick up everything from the back. You just need a wide angle with you, and you have to have a microscope which has with an inverter, more than your microscope have it. And with that, I'll close the session. And I think hope you enjoyed it. And all these surgeries are available in the book which we published last year. And no financial interest. So if you want to buy it, it's your choice. I'm not forcing anybody. And thank you very much.
Just a quick question, Professor Coker, about we all would agree on these microphthalmic eye not to put an IOL.
Yeah, that's right. I agree with 100%. Actually, what we did, we realized that the dimension at the back was also not right. There was a term called Nanophthale. What they say, it's a posterior stopping of the eye. The anterior part is normal. The white cornea could be 10 millimeters, which is normal. But when you see the axilla, they're falling very short. It could be 12, 13, 14, 15. So even if you calculate the power of the lens, it's going to be coming to about 44, 45 diopters, which you don't have. So best is to wait for them to grow. If they grow, to put a
moreover, that is exactly has been my experience, that these eyes, amazingly, because of whatever reasons, they grow exponentially and sometimes even may become equal to the other and almost try to surpass the other. What do you feel?
Right. So, Dr. Hayat, there was a study which was done by different groups. So it had Inotony, Lambert. So what they found was that if it's a unilateral cataract and a smaller eye, in few of the patients, they found that this will grow faster and more because of the peripheral blur and can go bigger. But the latest papers, in which I think Dr. Vasavada also commented something, they found it's an equivocal. So it may not. But at a given stage, when you're doing the surgery, if the eye is not anatomically fit to accept the lens, we should keep the patient phakic and wait for it to grow or give our contact lenses. And once it grows, and if it grows, we can always put an implant later on.
Dr. Our panelists, please, our other speakers, any comments, please, on this topic, please. Dr. Nihal, is she there?
Dr. Nihal showed wonderful surgery today.
Dr. Hyatt, I was just going to say, I agree with the abnormal eyes. You have to be very, very careful that you're not going to create more problems.
Right.
And I think that I think we're all agreed about that. The nanophthalmic eyes are a different story. You know, they get uveal effusion syndromes as well. So there's a lot to think about in terms of growth. There's some evidence that if you leave a child aphakic, they start talking about the refractive rate of growth, and it is faster in an aphakic eye than a crystalline lens placed eye. And there's plenty of evidence to show that. Of course, if they get glaucoma, that rate of growth increases. So, you know, it's a perfectly reasonable thing to do, and the right thing to do is to watch these eyes and leave them aphakic when they're abnormal.
Fair. Dr. Nihal?
Yes. Well, actually, I don't implant these very small eyes. It depends on the diameter of the cornea and not actually the axial length. If it is only microphthalmia, the axial lengths are short and the anterior segment is normal, I do implant. Maybe sometimes I reach 40 diopters intraocular lenses. And then I fit the rest with glasses. But there should be a normal sized anterior chamber. But in cases with a corneal diameter, small corneal diameter, it means that I have the anterior segment is small and a small capsular bag. Less than 10 millimeters, I don't implant intraocular lenses. I wait and see. If it doesn't develop glaucoma, I may implant in the future in sulcus.
Dr. Nihal, what's the youngest age you implant for a child?
The youngest age for congenital cataract in unilateral cases, 6 months, because there is massive change in the first 6 months in the curvature of the cornea. It's not a matter of axial length. The axial length, 80% is achieved in the first 2 years, but the corneal curvature decays change massively in the first 6 months. So under the age of 6 months, I don't implant. Considering the bilateral, the lowest age I implant 2 years, since I go for bilateral cataract surgery.
And
now,
Professor,
Professor Siddharth? Yeah, my take is if my eye anatomy is good, I don't go by the age. If my anatomy of the eye is good, I can go for the implant, especially for the unilateral ones, because unilateral are the one which gives you the maximum trouble. And I would like to ask Dr. Nihal, which company gives you plus 40? Because we don't have, we get 34 is the maximum, 30, 34, that's it. So can you please?
Yes, well, actually, for the past 22 years, I've been using Acrisoft, single and multi-piece intraocular lens. The multi-piece is only up to 30, but the single piece may reach to 40 diopters or more.
Is it? Because our understanding is that it's 30 and 34, not 40, maybe.
40.
Yeah, that's what, 40, 40 not 40, but 30, 30, and 34. So we tried.
Yeah.
Please go ahead.
I'm speaking about until 40 diopters, 40.
Okay, great. 40 is, I think, great. So now I would like to just now take the request, the last speaker, Dr. Michael Jones, from all the way from Sydney. He's the head of the department for pediatrics in Sydney Eye Hospital, to please take the stage.
My name is Dr. Michael Jones. I'm the head of the department at the Children's Hospital at Westmead in Sydney, Australia. Firstly, I'd like to thank the organising committee for the invitation and the honour of being asked to present, and in particular my friend Dr. Hyatt Khan, who I worked with many years ago at Sea Kids Hospital in Toronto. I'm sorry I can't be here in person to do this presentation. Unfortunately, the time difference with Sydney is particularly prohibitive, but I look forward in future to being able to meet many of you face to face. I thought it would be interesting to look at cataract surgery in the paediatric adolescent population, because there's very little that we know that can guide us from the evidence medically on what to do, as opposed to what we know for the infant or the very young child with pediatric cataract. Because of this, we rely heavily on individual cases and our own experience rather than the medical literature. And the issues in particular that we face are thinking about the patient's visual acuity and outcome in context of amblyopia, and having often very poor baseline visual acuity as a result. And then the potential for borderline normal visual acuity and the risk of surgery and loss of accommodation that we induce with cataract surgery. I felt the best way to do this was to share my experience with 3 cases, each which have a common theme based on the issues I discussed previously, but also draw out particular important features. And again, I hope that we can all learn from our experience together. The first case is a 14-year-old who was referred by an optometrist for an opinion regarding amblyopia. This was diagnosed when she was 5 years of age from vision screening. She was given part-time occlusion of glasses, and this was attempted for about a year with poor compliance and then ceased. She was systemically well, and otherwise there was no other medical issues and no other abnormality on her eye examination noted. When I met her, she had right visual acuity of 6 on 3.8 and left visual acuity of 6 on 60, pinholing to 6 on 30 using Snellen letters. Her right near visual acuity was N5 and the left N18. I performed a cycloplegic refraction, as I often find this particularly helpful with amblyopia, and she had a right eye acuity of plano with 0.5 seal at 90, and the left cycloplegic refraction measured 6 diopters myopia and 8.5 diopters of hypermetropic astigmatism at 100 degrees. I noted a peripheral wedge-shaped cortical cataract outside the visual axis in the left eye, which had previously gone undiagnosed. So this, of course, raised many issues. She came to me for consideration of how to treat her amblyopia, which was certainly a part of her visual problem, and also there was a huge refractive error in this peripheral cataract. We talked at length about refractive options, which included, of course, glasses, and she never improved significantly with refraction, and with the amblyopia residual, she was only able to get a best corrected visual acuity of 6 on 24. We talked about hard contact lenses and some way of correcting the high astigmatism with that, and she was very resistant to that idea. And of course, there's the option of laser corrective procedure for a partial correction of her refractive error, but that would of course also be later in life, as at 14 years of age, we'd wait for full visual maturation for this. She was very keen to have something done earlier. So considering her main issue being that she had a high astigmatism, we had to take this further in investigation. Unfortunately, I didn't have a pentacam in rooms at the time, and we performed an IOL master. Looking at that, there was quite a surprise, because you can see that there's a huge steepness in the keratometry. So a large part of the astigmatism was coming from her corneal refractive error rather than from the cataract causing astigmatism. This led to a very difficult decision to make, because the question of correcting, therefore, was not just based on taking out the cataract and the refractive component from that, but also trying to neutralize the corneal astigmatism. Now, at this stage and age, it's very appropriate to consider using a toric lens. She was, after a long discussion, surgery, and some important lessons in this case for, I think, considering anybody with high astigmatism in cataract surgery in the pediatric population. So the question in all these cases is, was it worth it? After a year, she attained her best corrected visual acuity of the pre-surgery amblyopic vision of 6 on 24. But amblyopia is not just a condition that stops at 8 years of age, or even at any age in particular. And 8 years later, she ended up with visual acuity in this eye of 6 on 9.5 plus 2, almost identical to her other eye. And as you can see, she had a very similar refraction. She went on to progress into a mild myopia, which she did in both eyes, but based on the target biometry looking for emmetropia, this is still, I think, a very reasonable outcome in her. She did require a YAG capsulotomy, and I think that's important. There wasn't a posterior capsulotomy necessary at the time of surgery, but of course we know that posterior capsular opacification's common in children and even in this adolescent population, and that needs to be thought of in the surgical decision making too. She was keen to get rid of the residual myopia, but she wasn't suitable for laser vision correction, having a refractive opinion as there isn't sufficient stromal bed, and she did have dry eyes. Notwithstanding this, she was still very happy with the outcome. This second case raises that same question of amblyopia in terms of pediatric cataract surgery. The first one was a huge surprise, as we didn't expect her to have such a great outcome given the amblyopia that she'd had for many years. It's a little bit different when you know the patient well and you've had them under your care for many years. This patient came from a very definite family history of autosomal dominant congenital cataracts. There was some vision screening done earlier, and the vision had always been in the normal range, and it was not until a routine vision check was found at 7 years of age to be subpar that the patient was referred for a formal ophthalmology review. Again, the mother had congenital cataracts and surgery at 16 years of age, so quite late in the piece, which is an indication of how things progressed in that family. And the brother had congenital cataracts, however, and had surgery at 18 months old. This patient had bilateral posterior polar cataracts. The visual acuity at the time was just better than 612 in the right eye and 612 in the left eye, but very importantly with normal accommodation N5 in both eyes. So the patient was watched, and there was a reluctance for surgery despite the family knowing so well the risks and benefits of surgery, and the parents and the family in their other child had a very good outcome. But at 14 the vision dropped further, and we were facing a decision based on the fact that the right visual acuity was 6/19, but the left visual acuity held up at 6/12. So the question was whether we needed to operate on one or two eyes, and very importantly the loss of accommodation that you were going to induce surgically, and that is a very big deal in paediatric patients, and in particular with the iPhone generation. There was a complication surgically potentially as well, because there's going to be the need for a vitrectomy given the posterior polar morphology, almost certainly. The decision was to proceed then with right cataract surgery. So 8 years later, the long-term follow-up showed an excellent result in terms of the right visual acuity, but despite aiming for emetropia and standard surgery without complication, there was still a refractive error, but with correction of the refractive error, there was 6/6 vision. But then we were faced with the question of what to do with the left eye, because that had also shown a change, and the cataract had progressed to giving the best corrected visual acuity of 6/30. We had a long talk about what to do, and the question of accommodation came in again, because at this stage of life the patient was working as a mechanic and wanted to be able to see clearly in that situation without having to have glasses. And with this generation, very importantly again, was very keen to be using an iPhone without glasses. So we went for aiming for a balanced myopia, and a toric lens was appropriate. And just to highlight the challenge of that when you're doing a posterior capsulotomy and you have the component of variability in lens position with rotation with a toric lens, and it's something that takes a little bit more time and a lot of care, and potentially even sometimes a little bit of luck, but you have to counsel your patient very carefully about that. Fortunately, we got what we were after, and he got a visual acuity of 6/6 corrected with the target myopia. So this third case is changing things slightly again, because we've looked at one eye surgery, we've looked at one eye at a time surgery, and now we're looking at two eye surgery. I first met this patient when they were 8 years of age, but they had congenital cataract diagnosed at 1 day of age. This was again due to a very strong family history of autosomal dominant congenital cataracts. The mother had bilateral cataracts and had been known in the family for 2 generations before this. He'd been treated with dilating drops until about 2 years of age, but then no treatment. Again, at 8 years of age, he was finding things more difficult, and it had a very borderline normal, but well within normal visual acuity, of 6/9.5 -1 in the right eye and 6/12 in the left eye. This was really surprising, and I'm sorry I haven't got a picture, but you can well imagine what it's like with some of these cataracts, with the visual axis being very obscured centrally in the undilated pupil. Of course, we had some indication of this when the child was dilated at a young age. And it's remarkable how well that treatment had obviously worked in those formative years to get to the level of acuity that he was enjoying later in life. But undilated, you could barely see around these dense central visual opacities. He had a cyclopedic refraction performed again, which is very important when you're dealing with any component of cataract and amblyopia. And this showed 3 diopters of hypermetropia in the right eye, and left eye was mostly astigmatism, measuring 2.25 diopters. We tried this, we gave him glasses, and there was no improvement in vision after a trial of glasses. So the big question here was, if we did something, even though you could only imagine you'd see better with those cataracts out of the way, the vision was actually still really relatively very normal. Would there be a persistent mild amblyopia? He wasn't needing glasses pre-surgery, and he was definitely going to be needing glasses post-surgery, and we were inducing loss of accommodation again. So fortunately, we were able to get the refractive outcome that we were after, and he had a very mild residual refractive error in the right eye and a mild astigmatism in the left eye, but corrected to 6 on 7.6 in both eyes. Now, he was frankly delighted with the change in vision, which isn't really just reflected in what we measure on Snellen acuity, because the quality of his vision, the brightness, the contrast, everything that he saw in terms of detail was more beautiful and brighter. It's important to note too that he also wanted to have a bilateral YAG capsulotomy, but just to note that in this population, this is a slightly easier procedure, and it took a little bit of bravery on his part, but he had that done in rooms without any issues. So pulling these cases together, I'd really like to emphasize a few points. Firstly, take the time to consider everyone very, very carefully as an individual case. Each have different circumstances, visual demands, and very importantly, expectations. If you're going to go through cataract surgery at any age, but especially with a pediatric patient in adolescence, you involve that patient directly in the conversation. It's not just a decision for the surgeon and the parents as it might be in an infant. We have other refractive options, and more in cataract surgery in children and in adults, we have to think of those refractive components too. The use of a toric lens, and then it's really the food for thought for another discussion, but using potentially in the future extended focus or multifocal intraocular lenses in children. The loss of accommodation is a very significant part of the discussion, in particular in informed consent in an adolescent patient. But don't forget, we measure acuity, but we don't often measure contrast sensitivity, and that can be as simple as taking time to talk about the visual problems that the patient's having, and particularly with other symptoms such as glare. And always the question of amblyopia. It's important to treat amblyopia at any age, and a component of what you're treating could actually be, of course, the cataract surgery again itself, as we saw how much the visual acuity improved in all these patients, partly from the refractive outcome, but also from a way of treating the amblyopia later in life. I'd like to thank you for letting me present these cases. I really hope that by sharing our experience, we can all learn a little bit more to bring to all our patients together. And I also hope it provides some food for thought for the panel in discussion later.
Thank you. Thank you so much. All the great talks by our colleagues. Special thanks to Dr. Nihal, Dr. Mustafa, Dr. Professor Coker, Dr. Ken Nischal, and last but not the least, to Mike Jones for these interesting talks. Dr. Majdi, would you like to close the session, please?
No, thank you. Thank you for everyone. Thank you, Dr. Khem, my colleague, my friend. Thank you for everyone. And we hope to see you the next time physically. Thank you. Thank you.
Thank you. Thank you. Thank you, everybody. Thank you, everybody.
Thank you, Dr. Nihal.